and welcome to our webinar. This is part of the Derry and Strabane Virtual Learning Festival. And my name is John O'Kelly. I am a general practitioner here in Derry and was former chair of the Royal College of General Practitioners in Northern Ireland. Today, we're going to talk on a subject of transforming healthcare by transforming ourselves through a pandemic, which is really to look at how the pandemic has affected us as health professionals and researchers, how it has changed our working and our working with ourselves, our colleagues, and our patients and the public. There is a chat function here at the bottom of Zoom, and I will keep an eye on it, and if anyone out there has a comment they would like to make or questions, I will be keeping an eye on those and will feed that into the discussion as needed. I'm absolutely delighted to welcome two very distinguished guests from the University of Ulster. Firstly, let me introduce Professor Louise Dubras, who is the Foundation Dean of the School of Medicine at the Ulster University here at Magee, and has been here since June 2018. She was formerly the Deputy Dean of Medical Education at King's College London. She has specialist interests in student transitions, development of professional identity, diversity and inclusion. She has an interest in the health of refugees and asylum seekers, and an interest in alcohol and addiction problems. And importantly, she also is a working GP, and she works here in Derry. Our second guest is Professor Tony Bjourson. Currently, he is leading the Ulster University COVID-19 task force, which is dealing with screening, serology, and contact tracing. He is a member of the COVID-19 Testing Scientific Advisory Consortium here in Northern Ireland. He is a director of the Northern Ireland Centre for Stratified Medicine, chief investigator, and he leads the National Genome Sequencing Initiatives for a range of human diseases. He is a founder and a director and on the board of the Clinical Translation Research and Innovation Centre, thankfully known to all of us as CTRIC, which translates biomedical research outputs to the patient bedside. So they both have distinguished track records. So let's start by just opening up a question to both of you. And what has the last few months with COVID-19 done for your professional work? How has it changed you both as individuals? How has it changed the way you think and work? I'm going to start maybe with you, Louise, as you're both an academic and also a working GP, and then we can move on to you, Tony, and the areas that you specialise in.
Thanks, John. Is that my cue? Thank you. I mean, I think you highlight the two aspects of my work, and it's been very, they've been very different kind of impacts, if you like. So anybody who has anything to do with education will know that the educational institutions have essentially closed their doors. Now, that doesn't mean that they have been shut. In fact, there has been an enormous amount of work going on behind the scenes, but no footfall. So that is true of our schools, and it's also true of us at Ulster University. So the job of being an academic has totally changed from being on campus, or as Tony's case, I'm sure, laboratory work and all the rest of it, to working from home, balancing all the challenges of being at home, confined, that I'm sure everybody else has experienced. The first probably 2 months or so of the pandemic, in fact, I increased my work as a GP. And again, anybody who's had contact with face-to-face or not face-to-face healthcare will know just how transformed we have found our work as clinicians. And the first sign of that has been closed doors with signs on saying, stop, don't come in. And that's unheard of for general practice, which has always prided itself on being accessible to its community. And the approach to work has been largely telephone, video consultations, and it's really been about trying to keep people away. And that has felt very counterintuitive on many, many levels. And I think the other thing that I would highlight in our work as clinicians has been the extent of personal learning that we have had to do. We have had, in the early days of the pandemic and the lockdown, we were getting new guidelines, new protocols almost daily, and this placed considerable pressure on us as teams and as individuals. So it's been a challenging time in which to be a GP, and I guess on a slightly flippant note, and John, you're modelling this yourself right now, is that GPs never wore scrubs, but all of a sudden we're going into work and wearing scrubs, which I think those of us who've been GPs for a while never really anticipated we'd be doing again. So yes, it's been quite hard.
Thank you. And the scrubs is great. I don't have to think about what I'm going to wear in the morning, which is great. I will pick up on some of those points shortly with you, Louise, but I just want to bring Tony in here because I imagine, Tony, for you, there has been a dramatic change in what you're doing and the work and how you're doing it.
Yeah, John, thanks. Yeah, as you said at the outset, we focus on personalised medicine, supporting the work of yourselves as GPs. And you would undoubtedly, along with Louise, argue that you've been practicing personalised medicine or stratified medicine since you started your careers, and unquestionably you have. So the work and the research that we focus on ordinarily attempts to improve diagnosis or treatment and more personalised diagnosis and better informed treatment. In the case of COVID-19, for most laboratory-based non-COVID work, it has essentially stopped. So anybody who isn't working on COVID-19 within the laboratory research area aren't doing any work at the moment. We've continued to work both on a pretty routine diagnostic level. You know, you think back to January, February, there were no tests really locally or regionally here for COVID-19. So we were invited by the Department of Health and by the Chief Medical Officer to assist the NHS in develop and ramp up COVID-19 testing for the virus. And so we have a team regionally here in Derry working between the University of Ulster, CTRIC, and the Elton Galvin Hospital scientists, where we've developed and implemented COVID-19 screening. So when people go and get swabbed, those swabs go and get the virus extracted and they're tested. And so we contributed to that, along with our colleagues in another university, in Queen's University, and in other establishments in Northern Ireland. So I guess because it's a relatively small place, everybody knows everybody else. We've called on our collective expertise from academia, from the NHS, from Veterinary Sciences Division, from Almac and Randox, and everybody has worked very collegiately, I have to say, to address that first need. And I think that has in some way gone to keep the numbers low in Northern Ireland. It's not the main reason, but it's one of the reasons. We were able to react, I would argue, pretty fast here because academia and the NHS and industry work together. So my work has not changed in terms of being a personalised medicine focus. And in terms of research, our focus is still on, you know, why do some people get a severe COVID infection while others are asymptomatic or have a mild infection? And that undoubtedly is due in part to age, which is well known, and also gender. And men are have a higher mortality. But in addition, like the previous pandemics and the MERS and so on, it's also encoded in our genetic material. So there are some people who are protected from infection, it's proposed, while other people are more susceptible, additional to environmental and existing morbidities and diseases that people have. So we have a very strong focus on, from a research perspective, at looking at the genes that are associated with predisposition to infection. And also then we have a team of colleagues in CTRIC working with our colleagues in Queen's University and in the Department of Health looking at antibodies. And we've heard a lot about antibody testing, and the jury is still out on, if you're tested positive for an antibody, what actually does that mean? It's not clear if that confers protection against subsequent infection, and it's not clear if that will mean you are infectious or not. So it's a very useful tool for epidemiological studies to give us some sort of a handle on the sort of exposure to the virus. On an international level, I think it's been extraordinary. Actually, while the leaders of the world, the main nations of the world, have been beating their chest and talking about biotech wars almost, and buying up all the drugs. I just spent from 2 to 3 on a teleconference with a group of international colleagues coordinated by the Broad Institute, where the UK Biobank, people from developed countries have all come together. They've put all the whole genomes together, and already there's really exciting data looking at what genes may predispose to severity of COVID, and it's unprecedented. The norms of academia and competition have been thrown by the wayside, and nobody's talking about secrecy and who's going to be authors and all of that. People are all hands to the pump, and it's in complete contrast to the chest beating that you hear, where there's an impression that various countries have to take the lead in vaccine development and so on. So I'll leave it there and come in maybe.
Yeah, it's very interesting to say that you talk about the international cooperation and the cooperation with scientists. Would you get that from the pharmaceutical industry as well? Have they been as open as you would wish to assist you in your research?
I have to say, in all honesty, yes. I mean, going back to February and March, when there was an urgent need to develop testing, in the same way there was a massive shortage for PPE and masks and protective equipment for clinicians at the coalface. Similarly, for testing, there was a major shortage of reagents and also the instrumentation. And I put out tweets and social media calls, and the response that I got from the pharmaceutical sector was amazing, and from the diagnostics and pharmaceutical and academic sector. And that's an opportunity for me to also thank the people who contributed to a crowdfunding initiative that we launched by the University of Ulster to provide robotic testing equipment that was crowdfunded by people here, and it's testimony to the community. So the stuff I'm talking about is not just what we have been doing. That has been very significantly impacted by the local community here, who really stepped up the plate and contributed 110, 112,000 in 30 hours to allow us to move fast and buy robotic equipment for testing. So it's an example of people using their power and their influence and taking the initiative. And I would be very keen to give ownership of those achievements to the public who have contributed to that.
And I think it's with ourselves as well. The community have been tremendously supportive. I know ourselves, we had visors being given, masks being given when we were having initial shortages of PPE. Just coming back to you there, Louise, on that, I'm sure you found that as well, that the community support or practice and what we did was quite amazing.
Oh, it was phenomenal, actually. I think the community here locally in the city has been just so supportive of anybody, I think, at the front line. And as you say, provision of visors, provision of, I think there was a company, for example, who normally would be spray painting vehicles, who had no need for their full bodysuits, and donated those to the practice for some of our more challenging house calls. And it, you know, it also extended to local businesses, you know, perhaps food providers who were having to shut down and were bringing supplies, and you know, our receptionists who were just run off their feet were just so appreciated that. So I would really like to add my thanks to Tony's, really, to the whole community for supporting us as frontline practices.
I think the way that, for instance, like O'Neill's changed to providing scrubs, which were sort of essential for us. It's been an incredibly steep learning curve, I've found, and probably both of you have found that as well. But how would you see that this has affected our patients, our public, over the last 3 months? So, Louise, again, can I ask you, with your role, what have you seen from your perspective of how this has changed for people, how they have interacted with us as a practice?
Yeah, I think there's been some phases that we have all been on. It's been this incredible journey of transformation, and in some extent, I liken it as the it's been a bit like going through a bereavement on some levels. So we know that the first, it's like we're grieving and we've been bereaved of what used to be normal, and so there was an initial phase, I think, of numbness where people couldn't quite believe what was happening, but they also did their very best to keep going as normal, and yet we couldn't keep going as normal, and so there was a period of adjustment, and then there was a period where I think people were perhaps confused, and I think from a patient perspective, not knowing quite how it all worked. The fact that their doctor couldn't let them through the door, was having to have telephone consultations, video consultations, couldn't do a house call, where perhaps normally a house call would have been a fairly routine thing that we might have done. And also the fact that, for example, we had to make real big changes in how we provide contraceptive services, in getting people in for routine blood tests, blood pressure checks, vitamin B12 injections, all of those kind of things. We had to completely rethink, postpone things. We changed the way that we've worked with our pharmacists, and so that there has been this real sort of learning, as you've referred to, and then it's almost as though, because we know we're in this for the long haul now, we get to that sort of, we're not through it, and at the moment I think we're in this sort of, it's a sort of semi-acceptance, but equally, one of the other things that we've seen is that people who have been so willing to hold on to problems and manage their own risks for themselves are 3 months in are finding that increasingly challenging, and so actually we've started to get very, very busy, and I think as practices, the challenge that presents for us is deciding how we relax our own lockdown in the practice. At what point do we start making more routine appointments available? How do we let more people in, recognizing that people are vectors of disease? How do we protect patients from us as much as us from them? So it's, yeah, I think that's probably the summary of some of the stuff we've been through. But you know, and I think maybe the other thing just to mention is the extent to to which the services have been reconfigured around us. We've been part of that change, but how we work with our hospital colleagues, how we refer patients, where services are located, the multidisciplinary teams that we work with, all of this, and each individual in each of those teams has been going through their own process of grieving for what was normal and what they don't have anymore. So it's been a very complex web of things we've been encountering.
And it certainly, the game has changed considerably, as you say, how we work with our secondary care colleagues. Even how we are working ourselves, and one of the areas is that we're using more digital technology. So we're using, as you mentioned, telephone. It's been around a long time, but we're now using video consultations. There are systems where we can send information directly to patients and back. And this seems to have taken on, using Zoom. It's something that we have developed. My concern then is how does this impact on our patients? It's all very well people in the public who are able to use technology, but there are groups of people who are going to be hard to reach, and this is both for our services, and Tony, when you're thinking of how do we reach people that we need to for testing and follow-up. So how do we reach those vulnerable groups? I know you did a lot of work with the refugees and the site, not easy to get to. And so I'm wondering how you both would feel in that. Maybe Tony will talk to you first about how do you develop systems that are available for everyone and not just for the few that can use smartphones.
Yeah, in preparation for this, I was kind of thinking, you know how it impacts and how it drives inequalities. I was kind of thinking what it has done on me personally as well. My wife would undoubtedly dispute this, but I would argue that my cooking skills have significantly improved, and my dietary, of a healthier diet. And that's maybe because I can afford to have a healthier diet, but I'm sure there's many people who have a much more unhealthy diet. And in the same way with technology for GPs and clinicians reaching out to patients, there are those in relation to trying to have effective homeschooling and that don't have the multiplicity of iPads and smart devices that can facilitate that. So I think one of the things when the postmortem is done on all of this, I think the forgotten cohorts in society that maybe don't have access to all the technology and devices, who we haven't heard of because they don't have a mechanism currently to communicate with us. I think you will find there will be a lost cohort that have been excluded, and the inequalities are maybe not as recognized currently. I think they come to be better recognized in about a year or so time.
Yeah.
Louise is looking to come in on that.
Yeah, well, can I come in?
Yes, absolutely. I was just thinking about, one of the things that was drummed into me as a medical student was Julian Tudor-Hart's inverse care law. And this to me seems like we're just going over old ground that there could be increasing health inequality here. We'd be very interested for you, Louise, to come in here and comment on what Tony has said there.
Yeah, absolutely. Thank you. You're right. I mean, I spent many years working, in fact, with homeless people as well as asylum seekers and refugees. And so I'm very accustomed to working as a clinician with people who are marginalised. And they would tended to have been people who were physically marginalised and perhaps emotionally and psychologically marginalised. But interestingly, in latter years of working with homeless people, quite a lot of them actually had smartphones. The problems for them were, how do they charge them up? And they tended to be on pay-as-you-go SIMs, so they needed to have access to Wi-Fi. They needed to be in a place where there was Wi-Fi, but actually once they were able to get onto social media, and in fact, it really transformed how we were able to work with those patients and contact them. But I think despite all of that, you know, you talk about hard to reach groups, John, and there still are. I mean, it's a bit of a contentious term, actually, hard to reach, I have to say, because I think that places that has a tendency to place the responsibility on the group, whereas actually you could say that the bit that's not very accessible is the service, and actually the service ought to be making more effort. Always difficult when we've been in the middle of a lockdown. But I think elderly people, people in temporary accommodation, people who haven't necessarily got access to devices, as you talk about. But actually, I think there's an additional element to it, and I think we've seen reference to that with some of the concerns about the rise in domestic abuse that seems to have occurred, and that is that people can't get a private space, a safe space, and where we are trying to have often quite personal, intimate conversations with people, certainly in relation to healthcare, if they haven't got privacy, then it's very, very difficult for them to do that, and therefore the sequelae, those long-term consequences to both physical and mental health, I think are likely to be significant.
Should there be an onus on governments giving out contracts to digital health groups and organisations who are providing digital health, that they have to take this into account and they have to deliver solutions for this? Don't we need to be imposing that on them? I don't know how you would both feel about that. Maybe Louise, you're going to comment first.
Oh, well, you'd get me on my soapbox there, John. And obviously, that's not appropriate because I'm sitting in my bedroom, which is why the Giant's Causeway is my background. But yes, I am of a firm belief that when we are designing any interventions, particularly technological interventions for our populations, we need to be mindful not just of the many and the people who can, but actually of the people who can't. They are the unheard voices, and I've always felt that my role as a GP is to advocate for those people, and so I am wholly on the side of aiming to make sure that patients are represented, but patients from every single group of society. It's so easy to alienate and marginalize without even knowing that we're doing it.
Tony, just before I bring you in on that, just to anyone out there who is watching us, if you want to make a comment or if you want to ask our distinguished guests a question, please do so through the chat function. So sorry, Tony, can I then just ask you to comment on that?
In relation to, I mean, good research has to be representative of society. So, I mean, any research design that doesn't capture the diversity of people in the population, it is flawed research. So, and I mean, I would argue that that is one of the failings of modern drug discovery. You know, like people are shocked when you say, you know, 30 to 50% of prescribed medications don't work in the people to which they're prescribed, and people go, what? I mean, but that is the reality, and if you look at why that might be, you know, drugs are trialed on nice clean cohorts. They frequently exclude the elderly. They will probably exclude people with multimorbidities, you know. So the drugs are developed and trialed on cohorts that are not representative of the majority of people who walk through a GP's door, which are, you know, I'm sure you'll be able to tell me, Louise and John, you know, I would guess it's around 50% of the patients are elderly and multimorbid, and I don't think that's representative of the clinical trials that are undertaken. If you look at the COVID mortality rate, you know, it's primarily in the over 65 age group and multimorbid. It's also there are higher mortality in deprived communities, and undoubtedly diet. And aside, I mentioned genetics, you know, and that's just because that's the business I'm in. But it's only part of the story. So the sort of life stressors and environmental exposures and trials that we encounter will determine not just what will we get COVID infections, but what other diseases we succumb to. So any clinical research study that doesn't or excludes an element of society is flawed in my view, and I think a lot of research studies are flawed for those very reasons.
I think you're spot on there in that I read papers and studies and look at them, and the exclusion lists are usually the patients that we're using these drugs on. Louise, would you like to comment on that from your point of view? You're on mute.
I'm so sorry. I actually don't think I have very much to add. I think Tony has captured it completely spot on, and it's actually, if you really start to drill down into what's going on, what we see in relation to COVID, but actually in relation to a lot of the other difficulties that we see, are that these are diseases where poor people do less well. Diseases of poverty, and surprise, surprise, people who are poor don't get included in research, possibly because they're in that so-called hard to reach group for all sorts of reasons, possibly because of lower levels of literacy, numeracy, whatever it is. But you know, it becomes this kind of repeating cycle of poverty, exclusion, and poor outcomes. So
just to encourage people out there who are here, if you want to comment, please use the chat function, or if you want to ask a question. Everyone's been very shy this evening. Just moving on, both of you are academics, you're both teachers, I presume, as well. What does this mean for the way we teach your students? What's the way it's going to be for you, Louise, teaching our new young doctors coming through? Tony, for your research students in your field. Does this change the game for you?
It changes it beyond recognition, I would say. So medical schools throughout the country have, at the beginning of the pandemic, just removed students from any sort of clinical learning. And of course, medicine is a hands-on subject. You can learn a certain amount from simulation, from working with actors, from looking at videos, and from Zoom tutorials, the kind of thing that we're doing now. But at the end of the day, as a doctor, you have to know that you can physically listen to somebody's heart, examine their lungs, their abdomen, and so on. So it's been very challenging, and as we begin to bring students back into placement, there's something about the numbers of students that can attend at any one time. And of course, there's also the service redesign that we spoke about a few moments ago, that the service they're going to be coming back into is going to look very different to the one that they left. So it's really all about trying to manage risk, and we also have to remember that whilst a lot of medical students are young and relatively fit, there are going to be those who are carers, there are going to be those who themselves have had to be shielded. So we have to support them to learn safely. So there have been some real challenges for medical schools. But we have to keep graduating doctors. You know, one thing we can be confident of is that we need doctors, and so we've had to think. People have had to think creatively about how we enable that.
And for you, Tony, how is it going to affect you?
I mean, I'm kind of a glass half full kind of guy generally. The pandemic, you know, I guess the closest comparison to this current pandemic is maybe the AIDS crisis that some of us are old enough to remember. I think while the pandemic and COVID-19 has taken the lives of friends and colleagues, and you know, this is not some distant pandemic in some underdeveloped part of the world. This is in our cities and in our towns and in our face. And I think it's while it has been devastating, it's a shame to waste a good crisis. And for me, I think every crisis presents opportunities, and similarly within the education and academic sphere, it undoubtedly, you know, I've seen all the reports of gloom and doom about universities shutting down. I mean, as academics, creativity and innovation's what we're about. Yeah, sure, there's going to be challenges. I already see people coming up with innovative ways of trying to fulfill online learning outcomes. As Louise has said, you cannot replace the personal interactions in many courses like medicine and clinical courses, and even in laboratory-based processes. While you can, you know, you often hear people, you know, have they got good hands for working in the lab? You can do stuff on a computer screen, you know, but when you let somebody loose on samples and things, if they contaminate everything, there is a bit of a problem. So I think it is changing the way we're working. I think I welcome the challenges, and I think our students are uncertain about, you know, do they book accommodation now to come back onto campus, for example? So it's a lot of the basic stuff. I think and I think the message from the University of Ulster is we will be providing blended learning online, but on campus as well, where government policy and university policy allows that. So we've already got all of our courses online, you know, in a short space of time since March, and we managed to get students graduated, and it wasn't ideal, but it was done, and I have no doubt that that will continue and will adapt.
Right, we have a few things now on the chat, so I'm going to just throw those into the mix if that's okay. We have from Peter Devine to all panelists, we're looking for a positive. Can we build on the quick adoption of technology witnessed during the pandemic to transform healthcare, the digital innovation? How do we make this type of healthcare access to everyone? And you did speak about the hard to reach groups. And so just on those comments, and thank you very much. We talked a little bit about digital health there. We did talk a wee bit about trying to keep some positivity. So let's be positive. All right, let's be positive. So IHE, I want you to give me something positive that we can take forward in the future and hang on to, that will make things better for us as clinicians and health professionals and scientists, and for our public, for our patients. Tony, I'll let you start with that.
I think regionally here, I'll break it into bite-sized chunks. I think regionally we're going to see the significant change that has occurred as a consequence of the pandemic. It hasn't all been bad. I mean, none of us like sitting in front of a Zoom call from we get out of bed in the morning. You know, we're all too accessible now, and there's no sort of cutoff at the end of the day. But I mean, is that worse than sitting for 2 hours in a car going to work? You know, where you sit, okay, maybe it's downtime, listen to the radio. So it has changed forever, I would suspect, the way we do work. I think it will have consequences on rental accommodation. I think a lot of companies will reduce their workspace. That people will be able to work from home. I think this has enabled many of us in society to reevaluate what our priorities are, and I think we're going to make adjustments that are better for our own personal quality of life. The technology is fantastic, and Peter online asked, you know, how can technology help that. This has been driven by technology. We wouldn't be having this sort of webinar without technology. So this sort of digital communication is here to stay and will definitely expand. I personally think it's brilliant. I hate sitting on a plane. I hate sitting on cars. So anything that prevents me from traveling 2 or 3 hours a day, I welcome. I think it also will empower people to maybe withdraw from the pressures of the busy lives that they ordinarily had before COVID, and they will reevaluate what is important in their lives and adjust their lives accordingly. Maybe spend more time with families. Maybe whether or not people continue to exercise. I note the sale of bicycles has increased, and I noticed the people walking, in the countryside has increased. That's maybe because they've been told you're not allowed to do it, except, for a short piece of exercise. Well, that continues post-COVID. It will be interesting to see.
I'll just interrupt here because I want to, conscious of our time here, Tony, and I want to get Louise to come in here, and I'm sure she's an avid cyclist as well. Yeah. So positivity from you, Louise.
Well, I am a very positive person. But I am also cognizant of the fact that sometimes in the positive changes there is a bit of churn and turmoil, and it's not always easy for people. So I'm actually going to pick on 2 examples of things that as a GP I think have been really positive. So one of those is that the sort of boundaries between the hospital and GP services have changed. I feel they've become less rigid. As a GP, it's been easier for me to have conversations with my hospital colleagues. And I think that's been a really positive thing for our patients. I think along with that, and this is the painful bit, so I'm sorry, I can't give you a wholly sweet thing. There's a little bit of bitterness to this pill, because I think there's going to be reorganisation of our services. I don't think, Tony talked about, why do we need big office buildings? The same could be said of, do we need as many hospitals as we have? Could we reorganise our services a little bit, a little bit more efficiently? So, and I think that's already been happening. Actually, I think we've seen moves of services to sort of hot spots and cooler spots and so on. So I think that may well be a fallout, but in my view, a positive one. I'm prepared to be challenged on that. But the other positive thing I think in general practice has actually been within our multidisciplinary teams, and one of the things that I have seen working really, really well, certainly in our practice, has been the level of personal support that our practice social worker has provided for our patients who've been isolated and shielding. And I think that if we are able to maintain that kind of input to our vulnerable older population, it may well help to keep them well into the future. So that is certainly something that I would like to see kind of maintained. And I think one of the questions that came in was, about the speed of change, and if we've demonstrated one thing through COVID, it's that we can change quickly. We can be really nimble, and we can be nimble as academics, we can be nimble as clinicians, and at whole, not just at individual unit or practice level, but actually at whole systems levels. And I would like to see some of that nimbleness, if that's the right adjective. I would like to see that maintained. We don't have to go through the bureaucratic hoops that we used to in order to make things happen.
Okay. Well, I'm conscious that time is getting on here, so I think what we'll do is maybe draw things to a conclusion. I think the last 3 to 4 months have been extraordinary for all of us. There's been a steep learning curve for everyone. On the positive side, there has been remarkable cooperation both within the health professional and from the community, which has been magnificent. There are areas that we still need to learn about. We hope that with the research that Tony and his colleagues will do, will help us to deliver care. I haven't even thought about winter and flu vaccines and all that there. There's obviously been an explosion of digital health innovations, and I think that is something that will continue, but with that comes a responsibility to be able to deliver that to everyone. So I want to thank everyone for joining us on this webinar and for your comments during the course of the meeting. It's been very much appreciated. I want to thank both Louise and Tony for their very interesting comments and their invaluable contributions. I wish you all well and please stay safe. Thank you and goodbye.